Hey everybody, welcome back to Moose Med. Thank you so much for joining me here today for GI Week 2. This is pretty much everything regarding Week 2 of GI, right? So it's going to be that general information, your clinical correlations, and some pharmacology towards the back end. This is going to be a super long video, so I did my best to kind of spice it up a little bit, make it funny where I could. So I hope you guys enjoy my feeble attempts for a little chuckle. All right, let's dive into it. All right, so let's start with the cephalic phase. Cephalic literally means head, and that's the key idea here. This phase is preparatory gastrointestinal response, meaning your GI tract starts working before food ever gets there. The cephalic phase is triggered by sight, smell, taste, or even the thought of food. You don't need to swallow anything, just seeing a burger or smelling coffee is enough to flip that switch. This tells you right away this phase is brain driven, not driven by food physically, stretching the stomach, or nutrients entering the gut. Mechanistically, this is mediated by parasympathetic vagal outflow. Parasympathetic means rest and digest, right? And vagal refers to the vagus nerve, cranial nerve 10. That pathway from the cerebral cortex, where you consciously perceive food, down to the medulla oblongata in the brainstem, and then out through the vagus nerve to the stomach. This makes cephalic phase a neural reflex, not a hormone first response. Importantly, this phase accounts for about 30% of total gastric secretion. That's not trivial. That's a significant chunk of stomach acid and enzymes that are already being released before the first bite. And so the primary purpose here is just to prime the stomach before food arrives. It's like revving the engine before driving your car. All right, so now that we know that the cephalic phase is brain-driven, let's break down exactly how that signal turns into stomach secretion. So the pathway is where the money is here. So the signal travels down the vagus nerve, and the vagus releases acetylcholine, or ACH. And acetylcholine is a neurotransmitter, meaning this is a neural signal, not a hormone floating through the bloodstream, right? So that acetylcholine then activates multiple target cells in the stomach. And this is important because the cephalic phase is not selective. It turns on the entire gastric machinery. First, parietal cells are activated, and these are cells that are responsible for secreting hydrochloric acid, or HCl. And acid helps denature proteins and sets the pH for digestion. Next, you have ECL cells, which stands for enterochromaffin-like cells, which will release histamine. And histamine is a powerful amplifier of acid secretion. It tells parietal cells to make even more acid. Then you have chief cells, which release pepsinogen and gastric lipase. And pepsinogen is an inactive enzyme precursor that will later become pepsin, the enzyme that is responsible for digesting proteins. And lipase helps with early fat digestion. Finally, you have G cells, which release gastrin, a hormone that further stimulates acid secretion and gastric activity. Even though gastrin is a hormone, its release here is triggered by neural input, not by food in the stomach. So the net effect of all of this is simple: increased gastric acid and increased digestive enzymes, all before food arrives, right? So that brings us to a very high yield rule. Cephalic phase secretion is acetylcholine driven, not stretch driven, and not nutrient driven. If the stomach hasn't been stretched yet and there are no nutrients present, but secretion is happening, that lets you know you're in the cephalic phase via the vagus nerve. Okay, so now we move from anticipation to action. So this is deglutition, which is the medical term for swallowing. And swallowing starts out voluntary, meaning you consciously decide to swallow. But very quickly, it becomes entirely involuntary. Once the reflex is triggered, you cannot stop it midway. That reflex is coordinated by a swallowing center in the medulla, part of the brainstem that handles automatic motor patterns like breathing and heart rate. Next is the upper esophageal sphincter, or the UES. Under resting conditions, the UES is normally contracted. This is important because it prevents air from entering the esophagus during breathing. So during a swallow, the upper esophageal sphincter relaxes briefly, allowing the food bolus to pass from the pharynx into the esophagus, and then it contracts again immediately. So now let's talk about the esophagus itself, because muscle type matters here. So the proximal or upper portion of the esophagus is made of striated muscle, which is under voluntary control. As you move downward, the distal 2/3 of the esophagus is smooth muscle, which is involuntary and controlled by the autonomic nervous system. This transition explains why swallowing starts voluntary and then ends involuntary. The primary mechanism that moves food through the esophagus is called peristalsis. Peristalsis refers to the coordinated wave-like contractions that push the food bolus downward towards the stomach. Again, this is not gravity dependent. You can swallow upside down, and that still works. Pretty cool. At the neurotransmitter level, contraction and relaxation are tightly regulated. You have acetylcholine, or ACH again, which causes contraction of esophageal smooth muscle. In contrast, you have nitric oxide and VIP, vasoactive intestinal peptide, which causes relaxation. And a way I like to remember that is that, the VIPs are very fancy, so they get a really big, nice, relaxing, relaxing chair. So VIP likes to relax. This balance between contraction above the bolus and relaxation below is what makes peristalsis effective. All right, so now we're going to focus specifically on the lower esophageal sphincter, or the LES, and why its normal physiology matters so much clinically. So under normal conditions during swallowing, the LES undergoes a transient relaxation. That relaxation is mediated by two inhibitory neurotransmitters, which are nitric oxide and VIP, which again is vasoactive intestinal peptide. These signals tell smooth muscles of the LES to relax at exactly the right time. Crucially, this relaxation is timed with esophageal peristalsis. So in other words, the sphincter doesn't just open randomly, it opens right when food is about to arrive into the stomach. So that allows the food to pass smoothly to get digested. So now let's talk about achalasia. So this is very common disorder. So achalasia occurs due to loss of inhibitory neurons in the esophagus. So when those neurons are lost, you get decreased nitric oxide and VIP signaling. Without those inhibitory signals, the lower esophageal fails to relax and instead stays in a high-tone, tightly contracted state. At the same time, you lose peristalsis in the distal 2/3 of the esophagus, which is the smooth muscle portion. So now you have a double problem. The sphincter won't open, and the esophagus can't push food forward. The consequences are predictable. Food cannot enter the stomach, so it builds up above the lower esophageal sphincter, and this leads to esophageal dilation upstream, meaning the esophagus stretches out over time, right, because nothing can pass through. Clinically, patients experience regurgitation of undigested food, which is huge. That will be a buzzword in your vignettes, weight loss, and dysphagia, which means difficulty swallowing. So importantly, the dysphagia occurs with both solids and liquids, which helps distinguish achalasia from mechanical obstructions. So the key contrast to lock in here is that achalasia means the LES can't open, right? And the flip side of that is GERD, okay? And GERD is what happens when the lower esophageal sphincter won't close, and that causes stomach acid to, get up into the esophagus. So a lot of the symptoms you can expect there could be, irritation of the esophagus, lots of burping, gastric reflux. And the other little key vignette detail you'll see is that it often gets worse with lying down, GERD will, right? And if you literally think of your stomach acid as a liquid, right, if you lie down and there's nothing preventing that liquid from going up into your esophagus, it will irritate it a lot more than standing up. Okay, so now that we understand what's going wrong physiologically in achalasia, this slide tells you about how we prove it diagnostically. So the gold standard diagnostic test for achalasia is esophageal manometry, and manometry literally means pressure measurement. A thin catheter with pressure sensors is passed through the esophagus, and it measures how well the esophageal muscles contract and whether the lower esophageal sphincter relaxes appropriately. In achalasia, manometry shows two hallmark findings. First, the increased resting lower esophageal sphincter tone, meaning the sphincter is abnormally tight even when the patient is not swallowing. And then second, there is failure of the lower esophageal sphincter relaxation during swallowing. So when the patient swallows, the pressure should drop, but it doesn't. At the same time, you see the absence of normal peristalsis in the distal esophagus. So if you're asked, what test definitely diagnoses achalasia, the answer is manometry. But now let's talk about barium swallow, which is often the first test ordered clinically because it's non-invasive and very visual. So in a barium swallow, the patient drinks a radio-opaque liquid, and X-ray images are taken as it moves down the esophagus. In achalasia, this shows a classic appearance called esophageal dilation with distal tapering, commonly described as a bird's beak or rat tail sign. The esophagus balloons out above the lower esophageal sphincter because food and liquid can't get through. So while the lower esophageal remains super tight at the bottom, everything else starts to balloon. So one important little detail is that barium swallow suggests achalasia, but manometry is the thing that confirms it. So imaging shows you what it looks like. Manometry tells you what is happening. Okay, now we're moving on to gastric phase, and we have our friend Coughing from Pokemon to bring us in here and represent it. So the gastric phase begins once food actually enters the stomach. This is where stomach responds directly to what it's holding. The key triggers here are gastric distension and the presence of peptides and amino acids. So distension just means the stomach wall is being stretched by food, and peptides and amino acids are the products of protein breakdown, which signal that digestion is actively underway. These stimuli activate two parallel pathways. First, you get a local enteric reflex. So this is the stomach talking to itself via the enteric nervous system, increasing secretion and motility without needing the brain. Second, you get a vagovagal reflex. That's a long reflex loop where stretch receptors in the stomach send signals up the vagus nerve to the brainstem, which then sends signals back down to the stomach to increase activity. Still parasympathetic, still acetylcholine driven. At the cellular level, this phase strongly stimulates G cells, which again release gastrin. And gastrin is a hormone that increases acid secretion, gastric motility, and mucosal growth. Gastrin also indirectly stimulates acid release by activating ECL cells, which secrete histamine, and histamine is a major amplifier of parietal cell acid production. So the net result of gastric phase is a large increase in gastric acid and enzyme secretion, along with stronger stomach contractions to mix food into the chyme. All right, next we have gastric secretions. And the reason we have our boy Peabody here hypnotizing you is because, hate to say it, you should know these cold. So this is me saying, you really want to memorize these, okay? So let's break these down. So first are parietal cells, and these cells secrete hydrochloric acid, or HCl, and intrinsic factor. So HCl lowers gastric pH, which denatures proteins and activates digestive enzymes, and intrinsic factor is essential for vitamin B12 absorption later in the terminal ileum. Without it, you get B12 deficiency and potentially pernicious anemia. Next are chief cells. These release pepsinogen and gastric lipase. Pepsinogen is an inactive precursor, also called a zymogen. Once it encounters the acidic environment created by HCl, it's converted into pepsin, which is the thing that actually digests proteins. Gastric lipase is the thing that begins fat digestion, but it plays a relatively minor role compared to pancreatic lipase. Then we have mucus cells, which secrete mucus and bicarbonate. This is the stomach's self-defense mechanism. So the mucus forms a physical barrier, and the bicarbonate neutralizes acid right at the epithelial surface, preventing the stomach from digesting itself. Next are G cells, which secrete gastrin. Gastrin is a hormone that increases acid secretion, gastric motility, and mucosal growth. It works both directly on parietal cells and indirectly through ECL cells. Which brings us to ECL cells, or enterochromaffin cells. And these cells release histamine, which strongly stimulates parietal cells to secrete acid. Histamine, again, is a major amplifier. This is why H2 blockers reduce acid production. You're blocking that histamine from binding to the H2 receptors. The exam pattern to recognize here is that acid secretion is synergistic, right? Acetylcholine, gastrin, and histamine all converge on the parietal cell. Blocking any one of them lowers acid. But histamine is the most powerful single driver. All right, so now let's zoom in on how gastric acid is actually made, and just as importantly, how the body knows when to shut it down. So acid secretion happens in parietal cells, as stated before, and the key player here is hydrogen potassium ATPase, also known as the proton pump. So this pump actively transports hydrogen ions into the stomach lumen in exchange for potassium. This is the final common pathway for acid secretion. Everything upstream is just regulation. So inside the parietal cell, carbon dioxide and water are converted into carbonic acid by carbonic anhydrase. Carbonic acid then dissociates into hydrogen ions and bicarbonate. The hydrogen ions are pumped into the stomach to form hydrochloric acid, while bicarb is transported into the bloodstream, causing the alkaline tide after meals. 3 major stimulatory signals activate the proton pump: acetylcholine from the vagus nerve, gastrin from G cells, histamine from ECL cells. These act synergistically, right? So they work together to produce much more acid than any single one. So now for the breaks. As gastric acid levels rise and pH drops, D cells in the stomach are stimulated to release somatostatin. Okay, and the way I like to remember that is somatostatin, D cells, right? So somatostatin is a potent inhibitory hormone, and it suppresses gastrin release from G cells, histamine from ECL cells, and direct acid secretion from parietal cells. So this is the classic negative feedback loop. More acid, more somatostatin, which will lead to less acid. So clinically and exam-wise, this matters because anything that disrupts this balance can cause a pathology. For example, loss of somatostatin signaling can contribute to hypergastrinemia and excess acid, increasing ulcer risk. So big takeaway here is acid production is powerful, tightly regulated, and self-limiting until disease interferes. All right, now this slide is about how the stomach moves food and controls when it empties, which is a balance between propulsion and regulation. So first, the stomach uses 2 main contraction patterns. The first is peristaltic contractions, which occur primarily in the distal stomach, especially the antrum. These contractions push gastric contents towards the pylorus. However, most of the chyme doesn't exit the stomach immediately. Instead, it gets pushed back into the stomach. So this process is called retropulsion, and it's critical for mechanical mixing and grinding of food. The second contraction pattern is tonic contractions, which occur mainly in the proximal stomach, like the fundus and body. So these are sustained contractions that help maintain pressure and act as a reservoir, controlling how much content is delivered distally over time. Underlying both of these contraction patterns are the interstitial cells of Cajal, or ICCs. And ICCs act as the pacemaker cells of the GI tract. They generate slow waves, which are rhythmic oscillations in the membrane potential. An important clarification here is slow waves do not cause contractions by themselves. They set the timing and maximum frequency of contractions. Actual contraction only occurs when slow waves reach threshold and are paired with excitatory input. So now let's talk about regulation, because gastric emptying is not just push the food forward. Gastrin plays a role in promoting gastric motility, but paradoxically, it also contributes to inhibition of gastric emptying when appropriate. So this helps ensure the stomach doesn't empty faster than the intestines can handle. On the intestinal side, CCK, or cholecystokinin, is a major inhibitor of gastric emptying. CCK is released in response to fat and amino acids in the duodenum, and its job is essentially to say, let's slow it down and hold up, right? So it decreases gastric motility and tightens the pyloric control so the intestine has time to digest and absorb nutrients properly. So the big concept this slide is teaching is that gastric emptying is regulated and not automatic. The stomach grinds and mixes aggressively, but it empties cautiously based on feedback from the intestine. Okay, so this slide pulls everything we just talked about and shows how acid regulation goes wrong clinically. So first is Zollinger-Ellison syndrome, and this is caused by a gastrinoma, which is a gastrin-secreting tumor. Because gastrin is being released independently of normal feedback control, acid secretion becomes excessive. Even though gastric pH is already very low, gastrin release doesn't shut off. The result is severe peptic ulcer disease, often with multiple or refractory ulcers, sometimes extending into the duodenum or jejunum. The high-yield mechanism here is loss of negative feedback. Normally, acid stimulates somatostatin to shut gastrin down. In Zollinger-Ellison syndrome, that feedback loop is bypassed. So next is peptic ulcer disease due to H. pylori. So Helicobacter pylori is a bacterium that colonizes the stomach and disrupts the mucus bicarbonate barrier that normally protects the epithelium from acid. It also alters local signaling, leading to increased acid injury to the gastric or duodenal ring. Clinically, this results in ulcer formation as well, which can cause epigastric pain, bleeding, or perforation. If bleeding occurs, patients may present with hematesis, which means vomiting blood, or melinia, which refers to black, tarry stools from digested food. So the other important thing here is H. pylori increases that acidic environment by secreting ammonia. And so the treatment logic here is that you have antibiotics for H. pylori and a proton pump inhibitor to suppress acid secretion, right? Because acid at the end of the day is just hydrogen. So if you have a proton pump inhibitor, you're going to stop hydrogen from being pumped into that stomach. So now we're shifting into the pancreas, and this slide is setting up the single most important concept, which is structure determines function. The pancreas has two distinct roles, and they are completely different in both what they secrete and where that secretion goes. First is the exocrine pancreas, right? And exocrine means secreting through a duct. The exocrine pancreas is responsible for digestion. This function is carried out by acinar cells, which produce digestive enzymes, and ductal cells, which produce an aqueous bicarbonate-rich fluid. These secretions don't go into the blood. Instead, they enter the pancreatic duct, which drains directly into the duodenum, the first part of the small intestine. So the enzymes digest the food, and the bicarbonate neutralizes gastric acid. The second role is the endocrine pancreas. An endocrine means secreting directly into the bloodstream. This function is carried out by the islets of Langerhans, which are clusters of hormone-producing cells embedded into the pancreas, and these cells release hormones like insulin and glucagon straight into the blood, not into the duct. In the pancreas, you're going to have alpha cells and beta cells, and alpha cells are going to be the ones that secrete glucagon, and beta cells are going to be the ones that secrete insulin. So you have the same organ, but two completely different outputs, right? Digestive enzymes and bicarbonate going through ducts to the intestine, hormones going into the blood to regulate metabolism. That's why the exam framing at the bottom matters so much. Same organ, two outputs, two delivery routes, duct versus blood. The pancreas basically has two wolves. Okay, so now we're focusing specifically on the endocrine pancreas, meaning hormone secretion directly into the bloodstream, right? So as stated before, we have our beta cells, and beta cells secrete insulin. The primary trigger for insulin release is high blood glucose, which typically occurs after a meal. So insulin release is also supported by parasympathetic nervous system, which fits with the fed state. The effect of insulin is to lower blood glucose. It does this by promoting glucose uptake and storage, especially in the liver and skeletal muscle. Skeletal muscle uptake occurs through GLUT4 transporters, which is an insulin-dependent glucose transporter. And insulin secretion is inhibited by the sympathetic nervous system, as well as somatostatin and glucagon, which makes sense physiologically. During stress or fasting, you don't want insulin to be lowering your blood sugar, right? So next are alpha cells, which secrete glucagon, and glucagon release is triggered by low blood glucose fasting and sympathetic nervous system activity. Its effect is the opposite of insulin. It increases that blood glucose. So glucagon acts primarily on the liver, where it stimulates glycogenolysis, which is the breaking down of glycogen, and gluconeogenesis, which is the production of new glucose. Then we have our delta cells, or D cells, which secrete somatostatin, right? Somatostatin, and that is our global inhibitor. It suppresses both GI and pancreatic secretions, meaning it dampens the release of insulin, glucagon, and digestive activity overall. The high-yield contrast at the bottom is exactly how it shows up on exams. Insulin is fed state, glucagon fasting state. If the patient just ate, insulin should be high. If the patient is fasting or stressed, glucagon should dominate. All right, so now we are switching back to the exocrine pancreas, and this slide is focused on exactly what it secretes and why each component matters. So the first major component is digestive enzymes, which are produced by acinar cells. These enzymes are organized by what they digest. For proteins, the pancreas secretes trypsinogen, chymotrypsinogen, and proelastase. Notice that these are all inactive zymogens, meaning that they're secreted in an inactive form to prevent the pancreas from just digesting itself. These will later be activated in the intestine. So for carbohydrates, acinar cells secrete amylase, which breaks down complex carbohydrates. For lipids, the pancreas secretes lipase and phospholipase A2, which are essential for fat digestion. And for nucleotides, the pancreas releases DNAase and RNase, which digest DNA and RNA from food. So the second major component comes from ductal cells, which secrete bicarbonate or bicarb along with water. And this bicarbonate-rich fluid has several critical roles. It neutralizes gastric acid entering the duodenum and activates pepsin, which only works in acidic environments. So, if you make it more basic, obviously it will stop working, and creates the optimal pH for pancreatic enzymes to function. So it's basically like rolling out the red carpet for the pancreatic enzymes to do their job. So these enzymes and bicarbonate secretions mix together in the pancreatic duct to form what we call pancreatic juice, okay, which then enters the duodenum. The exam logic at the bottom is extremely high yield. No bicarbonate does not mean no enzymes. It means enzymes are present, but they won't be working. So pancreatic enzymes require a neutral to slightly alkaline pH to function properly. And the reason we have our little frog down there is because when I heard pancreatic juice, I just thought pancreatic soup. And, if that helps it stick, there you go. Okay, now that we know what the pancreas secretes, this slide is all about how those secretions are regulated, and it comes down to a few key signals. First is CCK, or cholecystokinin, and CCK, again, is released when we have fatty acids and peptides in the duodenum. Its primary role here is to increase pancreatic enzyme secretion. So CCK mainly talks to acinar cells. At the same time, CCK decreases gastric emptying and gastric acid secretion, which slows down delivery of chyme so the intestine can keep up. CCK also causes the gallbladder contraction, and this ends up releasing bile to help digest fats. The next regulator is secretin, okay? And secretin is released in response to low pH in the duodenum, meaning acidic chyme coming from the stomach. Its main effect is to increase bicarb secretion from pancreatic ductal cells, right? You want to neutralize that as quick as possible to protect the intestinal lining. Secretin also decreases gastric acid secretions, reinforcing that protective effect. Then we have parasympathetic nervous system input, specifically acetylcholine, or ACH. And parasympathetic signaling stimulates pancreatic secretion, supporting digestion during the fed state, right? It's that rest and digest. In contrast, the sympathetic nervous system and somatostatin both inhibit pancreatic secretions. This makes sense during stress or fasting when digestion is not a priority. So the one-line memory at the bottom is exactly how this shows up. So CCK, enzymes, secretin, bicarbonate. And also CCK you want to associate, again, with squeezing that gallbladder. All right, so this slide pulls together pancreatic physiology by showing what happens when either the endocrine or exocrine slide fails. So first is diabetes mellitus, or as our wonderful man on the right calls it, diabetes, which is an endocrine pancreas problem. In type 1 diabetes, there is no insulin due to beta cell destruction. Because beta cell is absent, glucose cannot be effectively taken up into tissues, leading to persistent hyperglycemia. This is an absolute insulin deficiency. In type 2 diabetes, insulin is present, but there is insulin resistance. The problem here isn't insulin production initially, it's the inability of tissues to respond appropriately to insulin. Next, we have acute pancreatitis, which is an exocrine pancreas disorder. The key mechanism is premature activation of digestive enzymes inside the pancreas, instead of being activated in the intestine, as stated before. Enzymes like trypsin become active within the pancreas tissue itself, leading to autodigestion. So it literally ends up eating itself. Clinically, this causes elevated amylase and lipase in the blood, which is a classic lab finding. I would say amylase is more of a hint than lipase, but the slide also lists causes using the mnemonic I get smashed, which includes common triggers like gallstones, alcohol, and metabolic causes. I go over this more in my GI clinical correlations video. Then we have exocrine pancreatic insufficiency, abbreviated to EPI. In EPI, there are inadequate digestive enzymes, so nutrients, especially fats, cannot be properly digested or absorbed, and this leads to fat malabsorption, which causes steatorrhea, meaning fatty, greasy stools, along with weight loss. Common causes listed here are chronic pancreatitis and cystic fibrosis, and treatment is PERT, or pancreatic enzyme replacement therapy. It's exactly what it sounds like. You are supplying the missing enzymes. The exam takeaway at the bottom summarizes everything pretty nicely, which is pancreatic pathology is either a hormone problem or an enzyme problem. If glucose regulation is abnormal, think endocrine pancreas. If digestion and absorption are abnormal, think exocrine pancreas. Okay, so this slide is about where absorption happens in the intestine, and the key organization principle is that sodium and water drive everything else. So first, let's orient by absorption sites. The small intestine is where the majority of absorption occurs. This includes nutrients, electrolytes, and most water. The jejunum is especially important for the nutrient absorption, while the ileum continues absorption and has specialized roles like bile salt and vitamin B12 uptake. The colon, in contrast, is primarily responsible for absorbing sodium and water. Its job is not nutrient absorption, it's just concentrating stool. Now to the central concept of the slide, sodium absorption is the master driver. Sodium absorption across the intestinal epithelium is powered by sodium-potassium ATPase on the basolateral membrane of enterocytes. This pump actively moves sodium out of the cell and potassium into the cell, keeping intracellular sodium levels very low. Because sodium is constantly being pumped out of the cell, sodium from the intestinal lumen flows into the cell down its concentration gradient. Water follows sodium osmotically, meaning wherever sodium goes, water goes with it. That's why sodium movement essentially dictates water absorption. This is where aldosterone comes in. Aldosterone increases sodium reabsorption, especially in the colon, which in turn increases water reabsorption. So aldosterone helps conserve both water and fluid volume. Now the exam framing here is diarrhea. Diarrhea occurs when absorption is impaired or secretion overwhelms absorption. Because water follows sodium, anything that disrupts sodium absorption leads directly to diarrhea. This is why many diarrheal diseases are fundamentally disorders of electrolyte transport, not just too much water. So the high yield takeaway here is if sodium absorption fails, water stays in the lumen, then that leads to diarrhea. This slide builds directly off sodium and water by showing how potassium and chloride behave differently depending on the region of the intestine. We'll start with potassium. In the small intestine, potassium is absorbed passively, meaning it follows electrochemical gradients rather than being actively transported. As sodium and water are absorbed, potassium essentially comes along for the ride through paracellular pathways, moving between cells. In the colon, potassium handling changes. The colon can either absorb or secrete potassium, depending on the body's needs. This becomes clinically important because the colon plays a role in potassium homeostasis, especially when dietary intake or renal handling is altered. Now, chloride absorption is tightly linked to sodium absorption. In many parts of the intestine, chloride follows sodium passively to maintain electrical neutrality. However, chloride can also be absorbed through chloride bicarbonate exchange, especially in the ileum and colon. In this exchange, chloride is absorbed while bicarbonate is secreted into the lumen. This regional handling explains stool composition differences and acid-base effects tied to GI losses. Now, for the regional differences, which is very exam relevant, the small intestine is focused on, again, that bulk absorption, nutrients, sodium, water, potassium, and chloride. The colon is focused on fine-tuning electrolytes and water, concentrating stool and adjusting sodium and potassium levels under hormonal control, especially aldosterone. This is where diarrhea comes back into the picture, right? With diarrhea, you lose large amounts of potassium and bicarbonate, especially from the colon. That's why patients with severe diarrhea are at risk for hypokalemia and metabolic acidosis. So, high yield takeaway here is potassium loss is diarrhea complication, and the colon is the electrolyte regulator, not a nutrient absorber, whereas that small intestine is that nutrient absorber. This slide shifts from bulk electrolytes to micronutrient absorption, specifically iron and calcium, and transport proteins that control them. So we'll start with iron. Iron is absorbed primarily in the duodenum and proximal jejunum, and dietary iron is usually in the ferric form, which is iron 3+. And that cannot be absorbed directly. It must first be reduced to ferrous iron, Fe2+, at the intestinal brush border. Once in the ferrous iron form, iron enters the enterocyte through a specific transporter. Inside the cell, iron has two possible fates. It can be stored, bound to ferritin, or it can be exported into the bloodstream through a basolateral transporter, ferroportin. When iron exits the cell, it is converted back into the ferric form and binds transferrin, the plasma iron transport protein. So transferrin carries iron through the blood to tissues like bone marrow for red blood cell production. Regulation here is key. So the liver hormone hepcidin controls iron absorption by inhibiting ferroportin. High levels of hepcidin decrease iron absorption. Low hepcidin increase it. So now calcium. Calcium is absorbed primarily in the duodenum as well. This absorption can be active or passive, but the active pathway is especially important and is regulated by vitamin D. Vitamin D increases calcium absorption by increasing expression of calcium transport proteins in enterocytes. Without adequate vitamin D, calcium absorption drops even if dietary intake is normal. So, exam framing here. Iron absorption problems, you want to be thinking duodenum, ferritin, transferrin, and ferroportin. And then calcium absorption problems, you want to think vitamin D deficiency. So this slide organizes vitamins into two major groups based on how they're absorbed, which is extremely high yield clinically. First are the fat-soluble vitamins, which are A, D, E, K, easily remembered as ADEC. These vitamins require normal fat digestion and absorption. That means they depend on bile acids and micelle formation in the small intestine. If fat absorption is impaired, these vitamins are not absorbed effectively. Because they are fat-soluble, these vitamins can be stored in the body, particularly in the liver and adipose tissue. This also means deficiencies develop slowly, but toxicity is possible if intake is excessive. Clinically, fat-soluble vitamin deficiency is seen in conditions that cause fat malabsorption, such as pancreatic insufficiency, cholestasis, or small bowel disease. Next are the water-soluble vitamins. This group includes vitamin C and the B complex vitamins. These vitamins are absorbed directly into the bloodstream and do not require bile. They are generally not stored in large amounts, so deficiency can develop more quickly with poor intake or malabsorption. And an important expectation highlighted here is that vitamin B12, although it is water-soluble, its absorption is more complex. Vitamin B12 requires intrinsic factor, which is secreted by parietal cells in the stomach, and it's absorbed in the terminal ileum. So the exam framing you want to be thinking of is fat malabsorption could lead to deficiency of vitamin A, D, E, K, and terminal ileum disease or loss of intrinsic factor could lead to a B12 deficiency, or not could, it would, leading to anemia and neurological symptoms. So this slide ties absorption physiology directly into clinical lab findings and diarrheal disease, starting with lipemia. So lipemia refers to the presence of excess lipids in the blood, which causes serum to appear milky or cloudy. This happens after eating because dietary fats are absorbed and packaged into chylomicrons, which circulate in the bloodstream. This is exactly why fasting before blood tests is super important. If a patient eats before labs are drawn, circulating chylomicrons can falsely alter measurements, especially triglycerides and other lipid-based assays. So fasting labs are not about glucose only. They're about avoiding post-prandial lipemia that confounds results, right? So next we have diarrhea again, yippee, using this as an exam framework for absorption failure. So diarrhea occurs, again, when that secretion exceeds absorption or when absorption is impaired. So everything has to stay in the intestinal lumen, and if you have stuff in the intestinal lumen, then water follows, right? So that brings us to cholera, which is a classic example of secretory diarrhea. Cholera toxin works by increasing intracellular CAMP in intestinal epithelial cells. Elevated CAMP causes CFTR chloride channels to remain open, leading to massive chloride secretion into the lumen. Sodium and water follow chloride for that electric neutrality, and that will result in profuse watery diarrhea. So the critical exam point here is in cholera, the intestine is structurally intact, absorptive mechanisms are still present, but secretion is pathologically turned on. This is why oral rehydration therapy works. Sodium-glucose cotransporters remain functional, allowing sodium and therefore water to be absorbed even during active diarrhea. So the high yield takeaway here is cholera is that increased secretion, not decreased absorption, and then CAMP will lead to massive chloride output, which will lead to water loss. And there you go. Okay, so this slide is laying down the single organizing principle for GI absorption, and it's one you should always anchor to your exams, which is digestion enables absorption. The first key is that polymers must become monomers. The intestine cannot absorb a large macromolecule efficiently, so they have to break it down first. So for carbohydrates, that means they must be digested into monosaccharides like glucose, galactose, and fructose. For proteins, digestion produces amino acids, as well as di and tripeptides, which are small enough to be absorbed. And then you got lipids, and digestion produces fatty acids and monoglycerides, which then can be packaged for absorption. The slide then explains how digestion occurs, and there are two major locations. First are luminal enzymes, meaning enzymes that act in the lumen of the GI tract, and these include salivary enzymes, gastric enzymes, and pancreatic enzymes, and these do a bulk of the chemical breakdown. Second, we have our brush border enzymes, which are embedded directly into the apical membrane of intestinal epithelial cells. These finish digestion right at the point of absorption, especially for carbohydrates and peptides. So next is a major spatial concept. Absorption occurs primarily in the small intestine, right? We talked about this earlier, just hammering that point home. This is because the small intestine has a massive surface area due to its villi and microvilli, making it optimal for nutrient uptake. Then we get the exam framing, which is extremely important here. So malabsorption is defined by failure of digestion, transport, or packaging. That means problems can occur at multiple levels. If digestion fails, nutrients never become absorbable. If transport fails, nutrients can't cross the epithelium. If packaging fails, nutrients can't enter circulation properly. So the cartoon on the slide reinforces this idea visually because food can make it through multiple steps, but if one part of that system breaks down, nutrients end up in the toilet instead of the bloodstream. Okay, now we are zooming in on carbohydrate absorption, and the reason this slide is labeled high yield is simple. Transporters get tested constantly. So start with glucose and galactose. Both are absorbed across the apical membrane of enterocytes using SGLT1. And SGLT1 is a sodium-glucose cotransporter, meaning glucose and galactose only enter the cell coupled to sodium. This works because sodium is moving down its gradient, which is maintained by that sodium-potassium ATPase on the basolateral side. So no sodium gradient, no glucose uptake. Next is fructose, and this is where the classic trap lives. Fructose does not use SGLT1. Instead, fructose uses GLUT5 on the apical membrane. Easy way to remember that. 5 starts with an F, fructose, right? So GLUT5 works by facilitated diffusion, meaning it does not use sodium and does not require energy. So if you see fructose plus sodium in an answer choice, that's wrong, right? It's facilitated diffusion. So once inside the enterocyte, all monosaccharides exit the cell in the same way. They leave across the basolateral membrane via GLUT2 into the bloodstream, and GLUT2 is the universal exit door, okay? The slide then reinforces a principle we've already built. Sodium absorption drives water absorption. Because glucose and galactose are absorbed with sodium, water follows osmotically. This is why sodium-glucose cotransport is so powerful and why it's exploded clinically. The classic trap at the bottom is worth saying out loud. Fructose does not mean SGLT1. If the question says fructose and sodium together, eliminate it immediately, right? I can't drive that home enough. So easy way to remember this is, I just remember SGLT1 is different from GLUT5 and GLUT2, which are going to be the ones that are relevant for an upcoming exam. And so since it's so different, I just remember GG, as in good game. And GG stands for glucose and galactose. It's different, GG. And then for GLUT2, since it deals with all of the monosaccharides, it's going to be the super ripped Doge here. Whereas GLUT5, it only does fructose, so it's going to be this little guy named Cheem, right? So you got GLUT2, which does everything. GLUT5, only doing fructose. 5 fructose, and then SGLT1, GG, glucose and galactose. Now we're moving into protein digestion and absorption, and the key idea on the slide is that the body builds redundancy into protein uptake. The slide starts with an important negative statement. There is no protein digestion in the mouth. Saliva doesn't contain proteases, so protein digestion begins later. Next is the activation step, which is absolutely critical here. The enzyme enteropeptidase, located on the brush border of the small intestine, converts trypsinogen into trypsin. Trypsin is the master switch. Once activated, it activates other pancreatic proteases like chymotrypsin and elastase. Without this step, protein digestion fails completely. Then we get to absorption, where multiple pathways come into play. First, free amino acids are absorbed via sodium-dependent cotransporters. This mirrors what you saw with glucose, right? Sodium gradients drive uptake. Second, di and tripeptides are absorbed using pepT1, which is a hydrogen ion-dependent transporter. pepT1 is extremely important because it allows small peptides to be absorbed even when amino acid transport is impaired. Third, the slide notes that small peptides may cross intact via transcytosis, meaning they are taken up into the cell in vesicles and transported across without being fully broken down first. This is a minor pathway, but still clinically relevant. Once absorbed, amino acids enter the portal circulation and are delivered directly to the liver, where they are metabolized or redistributed. The high yield concept at the bottom pulls everything together here. So peptide transport protects absorption when amino acid transport is impaired. In other words, if one transporter system fails, protein nutrition is often preserved because the body uses parallel pathways. So in this slide, we have a classic example of how absorption physiology turns into a board-style disease logic using Hartnup disease. So first, the inheritance pattern. Hartnup is an autosomal recessive disease, meaning both alleles must be affected for the disease to manifest. The core defect is a neutral amino acid transporter, specifically SLC6A19. This transporter is responsible for absorbing neutral amino acids in both the intestine and proximal convoluted tubule of the kidney. One neutral amino acid that matters a lot here is tryptophan. With defective transport, tryptophan absorption decreases. That leads directly to the consequence listed on the slide. Tryptophan is a precursor for niacin, also known as vitamin B3. When tryptophan levels drop, niacin production drops as well, producing a pellagra-like symptom. Pellagra is classically remembered with its 3Ds, which are dermatitis, which is often photosensitive, diarrhea, and dementia. The slide also lists ataxia, which refers to impaired coordination, and amino acid urea, meaning amino acids spilling into the urine due to defective renal reabsorption. And so now the key compensatory mechanism is exam gold here. So even though amino acid transport is impaired, the intestine can still absorb di and tripeptides via pepT1, as stated in that previous slide, right? This partially bypasses the defective transporter. That's why treatment makes sense, right? A high protein diet, which increases peptide availability, right? And then you get nicotinamide supplementation to replace missing niacin. The board logic at the bottom summarizes everything pretty succinctly, which is peptide absorption can partially bypass amino acid transporter defects. So if you see a question with neutral amino acid loss but preserved nutrition, think pepT1 rescuing that, right? And think Hartnup disease. All right, now we're moving into lipid digestion, and this slide is emphasizing one core idea, which is fat digestion only works if multiple systems coordinate properly. The first step listed is emulsification. Large fat globules, oh my gosh, are broken into smaller droplets by bile acids and lecithin. This doesn't digest fat chemically, it increases its surface area, which is essential for enzymes to do their work effectively. Next is key enzymes, which is pancreatic lipase. Pancreatic lipase is responsible for the majority of fat digestion, converting triglycerides or TAGs into monoglycerides plus 2 free fatty acids. However, pancreatic lipase cannot function alone. It requires colipase, which anchors lipase to the lipid droplet in the presence of a bile acid. So without colipase, lipase is displaced and fat digestion fails. The slide then lists additional enzymes that contribute: lingual lipase and gastric lipase, which begin fat digestion earlier on in the GI tract. You have cholesterol esterase, which frees cholesterol. And then you have phospholipase A2, which digests phospholipids. Together, these enzymes generate fatty acids and monoglycerides, which then form micelles with the bile salts. Micelles are critical because they solubilize lipids in an aqueous environment, allowing them to approach the intestinal epithelial surface. The exam rule at the bottom is a high yield takeaway here, which is no bile or no lipase equals no micelles. And no micelles means no absorption. So if a patient has impaired bile secretion or pancreatic enzyme deficiency, fat digestion fails upstream before absorption even has a chance. Now that fats have been digested, this slide walks through how lipids are actually absorbed and transported, which is very different from carbs and proteins. Once micelles reach the brush border of the small intestine, fatty acids and monoglycerides diffuse into the enterocyte. Importantly, bile salts do not enter the cell. They stay in the lumen and will be recycled later on. Inside the enterocyte, fatty acids and monoglycerides are re-esterified back into triglycerides. And this step is critical because free fatty acids cannot circulate safely in large amounts, right? So these newly formed triglycerides are then packaged together with cholesterol, phospholipids, and apolipoproteins to form chylomicrons. Chylomicrons are large lipoproteins particles specifically designed to transport dietary fat. Here's the key difference from other nutrients. Chylomicrons do not enter portal circulation. Instead, chylomicrons are exocytosed into lacteals. Lacteals are lymphatic vessels located within the intestinal villi, and from there, they travel through the lymphatic system and eventually enter the bloodstream via the thoracic duct. This explains 2 high-yield clinical points. Fat absorption bypasses the liver initially, and disorders of lymphatic flow can cause fat malabsorption even if digestion is normal. The slide's takeaway is that lipid absorption requires packaging. If chylomicrons can't form due to apolipoprotein defects or intestinal disease, fats remain unabsorbed, leading to steatorrhea, which again is that fatty stool. Now we transition into the hepatobiliary system, which links the liver, bile, and intestine into a single functioning unit for digestion and detoxification. The liver is the central organ here. It produces bile, which is essential for fat digestion and absorption, and it also performs key metabolic and detoxification roles. Bile is not an enzyme, right? It's a detergent-like fluid that helps emulsify fats. Bile flows from the liver through the enterohepatic bile ducts and then into the common hepatic duct. From there, bile has 2 possible paths. When digestion is not occurring, bile is diverted into the gallbladder, where it is stored and concentrated. Water and electrolytes are absorbed out, making bile more potent. When food, especially fat, enters the duodenum, bile is released from the gallbladder into the intestine through the common bile duct, which empties into the duodenum at the ampulla of Vater. The key function of bile on this slide is fat handling. Bile acids allow fats to form micelles, which are absolutely required for lipid absorption. Without bile, fats remain insoluble and are lost in stool. So, the slide also is reinforcing that bile is a route of excretion. Substances like bilirubin, cholesterol, and drug metabolites are eliminated through bile into the GI tract. So some high-yield framing here is that, again, the liver makes bile, gallbladder stores and concentrates bile, and intestines use bile for fat absorption. If bile delivery is impaired at any step, that results in fat malabsorption, which, you guessed it, leads to that fatty poop again. Now we're zooming in on how bile is formed and why bile salts are the critical functional component. Bile is produced by hepatocytes in the liver. Its major component includes bile salts, bilirubin, cholesterol, phospholipids, and electrolytes. Among these, bile salts are the workhorses for digestion. Bile salts are synthesized from cholesterol in the liver. Primary bile salts are then conjugated, usually with glycine or taurine. Okay, and the way I kind of remember that, bile sounds like a gross, sticky thing, and glytar sounds also gross and sticky. So if you kind of remember glytar bile, it will stick pretty well. So glycine and taurine are the things that make it more water soluble, and once conjugated, we refer to them as bile salts. So the reason bile salts matter is their amphipathic nature. Amphipathic means they have a hydrophilic side and a hydrophobic side. This allows bile salts to act like detergents. They surround dietary fats and break large fat globules down to the droplets, enabling emulsification, and this massively increases the surface area for pancreatic lipase and yada, yada, yada. We talked about it. So this slide also emphasizes that bile salts are not consumed during digestion. Instead, they are reused through the enterohepatic circulation. After helping with fat absorption in the small intestine, bile salts are reabsorbed primarily in the terminal ileum and return to the liver via the portal circulation. This recycling is incredibly efficient, and losing bile salts, such as from ileal disease or resection, directly leads to fat malabsorption, and once again, you're going to get sick of me saying it, fatty poop. All right, this slide focuses on the gallbladder's two jobs, which are concentrating bile and releasing it at the right time. So bile is continuously produced by the liver, but digestion is intermittent. So when bile is not immediately needed, it is diverted to the gallbladder. And inside the gallbladder, epithelial cells actively absorb water and electrolytes, especially sodium and chloride. As water is removed, bile becomes much more concentrated, particularly rich in bile salts, cholesterol, and phospholipids. So an important distinction here is that the gallbladder does not make bile, right? It only stores and concentrates what the liver produces. Now, to release, this is very tightly regulated. So when food enters the duodenum, especially fat and amino acids, eye cells in the small intestine release CCK, or cholecystokinin, which we talked about previously, and it has two coordinated effects. The first, it causes gallbladder contraction, pushing that bile out. It causes relaxation of the sphincter of Oddi, which is the sphincter that allows bile to flow into the duodenum. This coordination is critical. Contracting the gallbladder without relaxation of that sphincter would do nothing useful. The purpose of bile release is to deliver bile salts to the small intestine so that fats can get that emulsification. And so without that timely bile delivery, fat digestion fails, even if pancreatic enzymes are present. An important enzyme to keep in mind here is 7-alpha hydroxylase, which is going to be that rate-limiting enzyme for your bile salt synthesis. Okay? So without 7-alpha hydroxylase, you're not going to be able to convert cholesterol into bile salts. So enterohepatic circulation is just a fancy term for that recycling of those bile salts, which we touched on a good amount in the previous lectures. But just to give you a little bit more detail on it, this process is highly efficient. Roughly about 95% of bile salts are recycled each cycle, which allows the body to maintain a relatively small bile salt pool while still digesting large amounts of fat. So again, just remember that the terminal ileum is where this occurs, and if it's diseased or removed, bile salts cannot be reabsorbed. Okay, so let's walk step by step through bilirubin metabolism because this pathway shows up everywhere. GI, liver, hematology. So we start with the source. So bilirubin comes from red blood cell breakdown. When red blood cells are destroyed, heme is released from hemoglobin, and heme is first converted into biliverdin and then into bilirubin. At this point, bilirubin is unconjugated bilirubin. That matters because unconjugated bilirubin is lipid soluble, meaning it does not dissolve well in water. Because of that, it has to travel into the bloodstream bound to albumin, which acts kind of like its carrier protein. Next stop is the liver. Hepatocytes take up unconjugated bilirubin from the blood. Inside the liver, an enzyme called UDP glucurinyl transferase conjugates bilirubin. Conjugation means adding glucuronic acid, which makes bilirubin, you guessed it, water soluble. This is critical transformation of the whole pathway, right? Once bilirubin is conjugated, it can safely be excreted into bile, and bile carries conjugated bilirubin into the intestine. In the intestine, gut bacteria convert conjugated bilirubin into urobilinogen, and from there, urobilinogen has two main fates. One, a small amount is reabsorbed and excreted in urine, and the other, the majority, is converted into stercobilin, which gives feces their iconic brown color. So, an exam trap, which this slide explicitly flags, is only conjugated bilirubin is water soluble, right? Don't forget that. Unconjugated bilirubin cannot appear in urine because it's bound to albumin, right? That carrier protein. So the high yield logic chain to write down would be red blood cell breakdown, unconjugated bilirubin, which is bound to albumin, remember, then liver conjugation, bile, intestine, urobilinogen, urine, and feces. Now we take the bilirubin pathway and apply it clinically with jaundice and first-pass metabolism. First, jaundice simply means excess bilirubin in the blood, which leads to yellowing of the skin and eyes. The key is figuring out where the pathway is breaking. Start with hemolytic jaundice. Here, the problem is increased red blood cell breakdown. More heme is being converted into bilirubin than the liver can process. This leads to elevated unconjugated bilirubin in the blood. Because conjugation and bile flow are still intact, bilirubin still reaches the intestine, so urine urobilinogen increases. So the exam pattern for hemolytic jaundice is that you're going to see an increase in unconjugated bilirubin, but you're also going to see that increase in urine urobilinogen. Next is going to be your obstructive jaundice. And in this case, the liver is conjugating bilirubin normally, but bile cannot reach the intestine due to the bile duct being blocked or liver disease. Conjugated bilirubin backs up into the blood because it's water soluble and it can spill into the urine. Since little to no bilirubin reaches the gut, urobilinogen products drop immensely, so urine urobilinogen is decreased or absent. That distinction is pretty much the board logic. So urine urobilinogen distinguishes what jaundice type you're dealing with here. So now the slide shifts to first-pass metabolism here. And first-pass metabolism refers to what happens when substances absorbed from the gut pass through the liver before entering systemic circulation. The liver extracts drugs by metabolizing them and or excreting them into bile. This determines a drug's bioavailability, meaning how much of that drug actually reaches the rest of the body. So, big takeaways here would be jaundice is a bilirubin problem. Urobilinogen tells you how to distinguish between what type of jaundice. And then first-pass metabolism explains why oral drugs may be less potent. All right, now we move into the large intestine, and this slide makes one thing very clear. The colon, remember, is not a digestive organ. It's drying, storage, and propulsion. So the colon receives three main things from the small intestine: indigestible food, like fiber, unabsorbed bile components, and remaining fluid. By the time components reach the colon, nutrients have already been absorbed. The colon's job is to manage what's left, especially the water and electrolytes. A key distinction on the slide is that the colon does not have distinct fasting versus fed motor patterns, unlike the small intestine. Motility in this colon is more about timing and coordination than continuous propulsion. The outcome of colonic functions are listed next. So you have concentrated feces achieved by water absorption, and then you have time defecation, meaning stool is stored until elimination is appropriate. The exam framing at the bottom is extremely high yield here. So colon, like I said, associate that with water and electrolyte handling, not digestion. All right, now we're focusing on how the colon moves contents, and this side emphasizes that colonic motility is about mixing, storage, and again, that occasional propulsion. So there are two major contraction patterns. So you got first are the haustral contractions, which are described here as phasic, meaning they are slow and rhythmic. These contractions occur with the haustra, the pouch-like segments of the colon. Their main job is to mix contents, which increases contact between stool and mucosa. That promotes water and electrolyte absorption. So a high yield association here is Houstra is mixing, not propulsion. Second are mass movements, labeled as tonic contractions. These are infrequent but powerful. When they occur, they move fecal material long distances, often from the proximal colon toward the distal colon of the rectum. Mass movements are what actually set the stage for defecation. The slide then notes that feces are stored until defecation reflex is triggered. In other words, the colon spends most of its time holding and dehydrating stool, not pushing it out. So now a quick clarification that often shows up as a trick question. Unlike the small intestine, the colon is not regulated by motilin, or a migrating motor complex, or MMC for short. Motilin and MMCs are fasting-related patterns that clear residual contents from the stomach and small intestine. The colon does not have a comparable fasting sweep. So if you see motilin or MMCs mentioned, you want to be thinking small intestine, not the colon. Now we get back to that water and electrolyte absorption. So we start with a big number perspective. About 9 to 10 liters of fluid per day enter the GI tract from diet and secretions. Despite that huge volume, only about 100 to 200 milliliters are ultimately lost in stool. That tells you how powerful intestinal absorption is and how catastrophic it is when it fails. So most colonic absorption occurs in the proximal colon, and this is where the majority of water and electrolytes are reclaimed before stool moves distally. Sodium absorption is the central driver here, as per usual, and sodium enters colonocytes through the E-sodium channel, right, which is epithelial sodium channel. On the apical membrane is where that is located, and this process is enhanced by aldosterone, the same hormone that acts on the kidney. As sodium is absorbed, it creates an electrical gradient. That gradient pulls chloride across the epithelium, and as always, water follows. So again, sodium movement dictates that water movement. This slide introduces the gut microbiome and explains why it's not just passive. So it actively contributes to energy extraction, electrolyte absorption, and pH regulation in the colon. Start with the microbiome itself. The colon contains a defense population of bacteria that ferment undigested carbohydrates, especially dietary fiber that escape digestion in the small intestine. The products of this fermentation are short-chain fatty acids, or SCFAs, primarily acetate, or propanoate, and butyrate. These short-chain fatty acids serve three major functions. First, they are an energy source. So colonocytes preferentially use butyrate as their primary fuel, so the health of the colonic epithelium actually depends on bacterial metabolism. Second, short-chain fatty acids enhance sodium and water absorption. So short-chain fatty acids are absorbed along with sodium, which reinforce fluid reabsorption. This is another reason the colon is so effective at drying stool. Third, short-chain fatty acids lower luminal pH. As short-chain fatty acids accumulate, short-chain fatty acids are just that, they're acids. So the more that are in the lumen, the more acidic that lumen will become. This will inhibit the growth of pathogenic bacteria, and it increases mineral solubility, supporting absorption. That lower pH does, that is. So the exam framing here is, if you disrupt the microbiome, you lose short-chain fatty acids, which impair water absorption, which will lead to, you guessed it, diarrhea. This is why antibiotics can cause diarrhea even without infection. They reduce short-chain fatty acid production by killing normal gut flora. This slide groups together the appendix and two classic colonic disorders, and the unifying theme is motility and immune function. So first, the appendix. The appendix is a narrow, blind-ended pouch extending from the cecum. For a long time, it was considered vestigial, but now we understand it has an immune role. It contains a high concentration of gut-associated lymphoid tissue, or GALT, meaning it participates in immune surveillance of gut bacteria. It also is thought to act as a reservoir of normal gut flora, helping repopulate the colon after infections. So next is appendicitis, which is inflammation of the appendix. Appendicitis usually occurs due to luminal obstruction, commonly by a fecalith, which is just a poop rock. Obstruction leads to increased pressure, bacterial overgrowth, ischemia, inflammation, Clinically, pain often starts as a periumbilical pain and then localizes to the right lower quadrant as the parietal peritoneum becomes involved. Untreated appendicitis can progress to perforation and peritonitis, which is why it's treated as a surgical emergency. Now, Hirschsprung's disease, which is very high yield, is caused by the absence of enteric ganglion cells in the segment of the colon. And this happens because neural crest cells fail to migrate during development. Without ganglion cells, the segment of bowel cannot relax. The result is functional obstruction. So stool accumulates upstream, causing colonic dilation or megacolon, which, while the affected segment remains constricted. So first and most obviously, amino acids are used for protein synthesis. They are assembled into structural proteins, enzymes, transporters, receptors. Essentially anything in the body that does work is made of protein. Second, amino acids serve as precursors for critical molecules. This includes neurotransmitters like glutamate, GABA, serotonin, dopamine, hormones such as peptide hormones, and nitrogen-containing compounds including heme, creatine, and nucleotides. So if amino acid supply is disrupted, the effects go far beyond muscle. Signaling and metabolism are also affected. Third, amino acids are a major source of nitrogen. Nitrogen is required for nucleotides and many biosynthetic pathways. Excess nitrogen, however, is toxic, which is why it must eventually be converted into urea and excreted, which we'll get into later. Fourth, we have amino acids can be used for energy. When dietary intake exceeds the needs for synthesis, amino acids can be deaminated, and their carbon skeleton can enter metabolic pathways like the citric acid cycle and gluconeogenesis. You know what that means? You have more things to memorize. In general, though, amino acids are broken up into two groups, which are essential, meaning you have to get them from your diet, and non-essential, meaning they can be synthesized. Okay, this slide introduces transamination, which is the central mechanism the body uses to make and reshuffle amino acids. Transamination is the process by which an amino group is transferred from one molecule to another. And importantly, this does not create or destroy nitrogen, it just moves it. So the reaction involves two key players. You have an amino acid, which donates its amino group, and then you have a keto acid, an alpha keto acid, which receives that amino group and becomes the new amino acid. These reactions are catalyzed by enzymes called aminotransferases, also known as transaminases. And these two, the two most clinically relevant examples are ALT, which is alanine aminotransferase, and AST, aspartate aminotransferase, which you'll later see in liver injury markers. A critical cofactor for all transamination reactions is vitamin B6. In its active form, pyridoxal phosphate, or PLP, is when it is used to do this transamination. Without PLP, transamination cannot occur. So vitamin B6 deficiency directly impairs amino acid metabolism. Functionally, transamination allows the body to synthesize non-essential amino acids, interconvert amino acids based on the metabolic needs, collect nitrogen safely for eventual disposal. And so one amino acid is especially important here, and that's glutamate. Glutamate acts as a nitrogen hub, accepting amino groups from many different amino acids. Once nitrogen is consolidated into glutamate, it can safely be handed downstream. So this slide just focuses on those non-essential amino acids as we described earlier. And so non-essential amino acids, again, are made through those transamination reactions. And in those reactions, again, amino group is just transferred onto a carbon skeleton. So most of these carbon skeletons come from glycolysis or the citric acid cycle. So for example, pyruvate can be transaminated to form alanine. Oxaloacetate becomes aspartate, and alpha-ketoglutarate can become glutamate. This is why metabolism is so interconnected here. Amino acid synthesis is directly tied to energy pathways. So glutamate, again, plays that central role, acts as the main amino group donor, allowing for nitrogen to be distributed to make other amino acids as needed. From glutamate, the body can generate amino acids like glutamine, which is especially important for nitrogen transport. The slides also emphasize that synthesis of non-essential amino acids requires adequate nitrogen and vitamin cofactors, especially, as stated previously, PLP, or vitamin B6. Clinically this matters because illness, stress, or malnutrition, the demand for certain amino acids will start to increase. And in those contexts, they can become conditionally essential, meaning dietary intake becomes extremely important. All right, now we're shifting from what amino acids are used for into the body into now how we break them down. So amino acid catabolism occurs mainly in the liver, and that's because the liver is an organ responsible for nitrogen disposal. It's where the urea cycle lives, which we'll get into in a second. So it makes sense that most amino acid breakdown funnels here. There's one important exception listed, which is branched chain amino acids, or BCAAs, which are leucine, isoleucine, and valine. These are primarily metabolized in skeletal muscle, not the liver. Okay? That's a classic, just first order exam fact. Next, the slide highlights two major nitrogen removal reactions. The first is transamination, which we've already talked about. And then the second is oxidative deamination. And this is where nitrogen is actually removed from glutamate and released as free ammonia. This step mainly occurs in the liver and is what commits nitrogen to eventual disposal. So that leads to our next key line here. Nitrogen is ultimately excreted as urea. So free ammonia is super toxic, so the body never lets it circulate freely for very long. It gets rapidly converted into urea in the liver. And so, honestly, with this is just kind of blunt memorization. I really recommend throwing down some flashcards and just drilling this, because so many of these will show up as just first order, do you know it or do you don't questions on exams. So just stare at this graph, know what amino acids can enter what cycle where as what, and you should be pretty set. But like I said, this unfortunately is just one of those things in medicine where it's just, you got to know this cold. Okay, so this slide is about where amino acid carbon skeletons end up and what determines whether they can make glucose or ketones. So first, you got glucogenic amino acids, and these enter glycolysis or the citric acid cycle as intermediates like pyruvate or oxaloacetate. Because of that, they can be used for gluconeogenesis, meaning they can ultimately make glucose, glucogenic. Next, you have ketogenic amino acid, and thankfully, there's only two of these. So if you just remember these two, you can remember all the other glucogenic ones, because it just won't be these two, and that's leucine and lysine. These break down into acetyl-CoA or acetoacetate, which cannot be converted into glucose. Instead, they are used to form ketone bodies. Now we apply amino acid metabolism to your classic board diseases. And again, a lot of this is going to be some pattern recognition. So once you kind of do a couple practice problems with these should stick. So maple syrup urine disease, or MSUD. MSUD is caused by a defect in branched chain amino or alpha keto acid dehydrogenase. That enzyme is responsible for breaking down the branched chain amino acids of leucine, isoleucine, and valine. So when the enzyme doesn't work, these amino acids, especially leucine, build up and cause neurotoxicity. The classic clue is sweet maple syrup smelling urine. Clinically, patients present with poor feeding, vomiting, lethargy, and neurologic deterioration. Next up, we have homocystinuria. The defect here is that cystathione beta synthase, an enzyme involved in methionine metabolism, is defective, right? So when this enzyme is defective, homocysteine and methionine accumulate. And the hallmark feature here is going to be marfanoid body habitus. So you're going to see some Marfan-like syndrome. You're going to see that lens, their eye may be shifted up. You know, they may have some longer appendages. And then they may have some thromboembolic disease. And so the exam shortcut here is just basically if you see Marfanoid-like features being brought up, high methionine, you want to be thinking homocystinuria. And finally, you have PKU. And PKU is caused by a deficiency of phenylalanine hydroxylase, and that enzyme is what converts phenylalanine into tyrosine. And when this fails, phenylalanine accumulates and becomes toxic and will start damaging the developing brain. So classic findings include intellectual disability if untreated, musty or mousy odor of breath, sweat, or urine, and often lighter skin and hair because tyrosine is a precursor for melanin. So with PKU, easy way to remember it, PU, musty odor, right? PKU, musty odor, which you will commonly see in vignettes trying to point you towards PKU. All right, now we get to the reason the urea cycle exists at all, and the answer is very simple. Ammonia is dangerous. So amino acid catabolism produces ammonia, written here as NH4+, and this happens every time nitrogen is removed from amino acids. The problem is that ammonia is highly toxic, especially to the central nervous system. So the slide explains why ammonia is so dangerous. Ammonia reacts with alpha-ketoglutarate to form glutamate. That depletes alpha-ketoglutarate from the citric acid cycle, which means less citric acid cycle activity, decrease in ATP production. Neurons are extremely energy dependent, so this quickly leads to a neurological dysfunction. To prevent this, the liver converts ammonia into urea. Urea is non-toxic, water-soluble, and easily excreted by the kidneys. That conversion happens through the urea cycle. And this safely packages nitrogen for elimination. The slide also gives a reference range. So normal blood ammonia is about 30 to 60 micromolar. And levels above this are dangerous. I would say for the upcoming exam, not very important to know that, but just fun to sprinkle it in. The exam framing at the bottom is one of the most important one-liners. It's just hyperammonemia, right? So just lots of ammonia in your blood is going to be a neurologic emergency, which is why this is so critical. Okay, and here we have the urea cycle in all its glory. I'm not going to talk through this because honestly, I really recommend just writing this out a bunch of times or using flashcards, but I will give you a couple things that will help you just lock this in. So for first and foremost, the rate-limiting enzyme here is called CPS1. Okay, there's another rate-limiting enzyme called CPS, but it has a 2 at the end of it, and that's going to be used for pyrimidine synthesis, which we'll see later on. The way to remember that CPS1 is for the urea cycle is because CPS also stands for Child Protective Services. And so if there is an adult who is urinating on a child, they will go there first. Easy way to remember that. The urination part should cue you into urea cycle, CPS, 1, the 1 being first, right? So CPS 1. I know it's pretty foul, but it will stick. The other way that's pretty easy to remember all the intermediates is this little mnemonic here, which is orange-colored cats always ask for awesome umbrellas. And the thing to remember here is that this mnemonic includes the things that get added in as part of it. So it starts out with ornithine, and then it goes to carbonyl phosphate, and that combines to create citrulline, and then you have aspartate, which combines with citrulline to form arginosuccinate, and then you poop out fumarate. And anyway, like I said, if you just run through this and keep that mnemonic in mind, you will get this no problem. And also, the reason the urea cycle is pretty great is because all the enzymes are actually named after the thing that they are making. Pretty cool. Okay, so now we're just getting into the urea cycle disorders here. Okay, so first and foremost, obviously they're all going to be bad if you can't get rid of ammonia, right? Because like we said, that could lead to a lot of neuro disorders. But diving into the first specific one, we have CPS1. And if you get rid of that first rate-limiting step of the urea cycle, that's bad. That's not great, especially because that step happens in the mitochondria and is required to even start the cycle. So it will cause severe neonatal hyperammonemia, right? So you're going to get a lot of ammonia in the blood. So these babies often present very early with lethargy, vomiting, seizures, and coma. Next, you're going to have ornithine transcarbamylase deficiency, which is X-linked and is the most common urea cycle disorder. The key pattern here is you're going to see an increase in ammonia and an increase in orotic acid. So why orotic acid? Because carbonyl phosphate builds up in the mitochondria and spills into the cytosol, where it can get shunted into pyrimidine synthesis, which we'll get into later, but that will then produce an excess of orotic acid. So that leads to the classic exam ruling, which is hyperammonemia and an increase in orotic acid would lead you to OTC deficiency. So next we have argininosuccinate synthase deficiency, also called citrullinemia. And here, citrulline accumulates because it cannot be converted into argininosuccinate. Pretty self-explanatory. Next, you have argininosuccinate lyase deficiency. And this causes accumulation of argininosuccinate along with elevated citrulline. And then finally, you have arginase deficiency. And this is usually later onset compared to the other urea cycle disorders and is characterized by elevated arginine. Across all of these, the symptoms are very similar, right? You're going to get poor feeding, vomiting, lethargy, brain swelling, seizures, coma, all because you're getting ammonia in your blood, right? That's just all around bad for all the reasons stated before. So this slide answers a key question. How does the body turn the urea cycle on when nitrogen load increases? The important point on the slide is that the urea cycle is regulated at its first step. The enzyme CPS1 is the rate-limiting enzyme of the urea cycle. CPS1 does not function at baseline. It requires an activator. That activator is called N-acetylglutamate, abbreviated as NAG. So NAG is synthesized from glutamate and acetyl-CoA, and its production is stimulated by arginine. This is the logic loop that this slide is basically trying to hammer home here. High protein intake will lead to more amino acid breakdown. More nitrogen leads to more arginine. More arginine leads to more NAG. More NAG leads to activation of CPS1, and then more urea cycle flux, ammonia detoxified. Okay, so why nucleotide metabolism matters? So first, nucleotides are the building blocks of DNA and RNA. That means any process involving cell division, growth, or repair absolutely depends on a steady and balanced supply of nucleotides. If nucleotide synthesis is impaired, rapidly dividing tissues like bone marrow and GI epithelium are first to suffer. Second, nucleotides are energy carriers. ATP and GTP are nucleotides, and they drive essentially every energy requiring process in the body. So nucleotide metabolism isn't just about genetics, it's about cellular energy economics. So third, nucleotide functions as signaling molecules as well. And some examples would be cyclic AMP or cyclic GMP, which act as second messengers in hormone signaling pathways. If nucleotide metabolism is altered, signaling cascades break. Nucleotides are also components of essential cofactors like NAD+, FAD, and CoA. These are required for redox reactions and metabolism across the board. So basically, the slide makes the clinical connection that disorders of nucleotide metabolism lead to immunodeficiency, anemia, neurologic dysfunction, and gout. That's because tissues with high turnover or high energy demand are especially sensitive to nucleotide imbalance. Okay, so this slide introduces de novo synthesis, and that just means building purine nucleotides from scratch, like new, de novo. The key idea is that purines are assembled stepwise directly onto a ribose backbone. Everything starts with PRPP, which stands for 5-phosphoribosyl 1-pyrophosphate. PRPP is derived from ribose 5-phosphate and acts as the activated ribose scaffold for nucleotide synthesis. No PRPP, no de novo purines. My bad. The committed and rate-limiting step of purine synthesis is catalyzed by glutamine PRPP aminotransferase. This enzyme adds first nitrogen to the ring and commits the pathway to purine synthesis. This is the key regulatory checkpoint here. From there, the purine ring is built piece by piece using atoms donated from several sources, like glutamine providing its nitrogen, glycine contributing both carbon and nitrogen, aspartate contributes nitrogen, and then you got formal THF, which donates one carbon unit. This multi-step process eventually produces something called IMP, or inosine monophosphate. IMP is the branch point purine. It can be converted into AMP or GMP, depending on cellular needs. So regulation is classic feedback inhibition. So if you have high levels of AMP and GMP, that will inhibit glutamine PRPP aminotransferase, slowing the pathway when purines are abundant. And so here we're going to talk about how the cell keeps AMP and GMP production balanced instead of overproducing one at the expense of the other. Everything starts at IMP, which, like I said, is that branch point of purine synthesis. So here's the key regulatory logic. To make AMP, the pathway requires GTP as an energy source. To make GMP, the pathway requires ATP as an energy source. So that cross dependence is not an accident. It's built-in balancing mechanism. If ATP levels are high, GMP synthesis is favored. If GTP levels are high, AMP synthesis is favored. This prevents the cell from drifting too far toward only one purine nucleotide. And so basically this slide just highlights that feedback inhibition as well. So AMP inhibits its own synthesis pathway and GMP inhibits its own synthesis pathway. So each end product slows down the pathway that makes it while still allowing the other branch to proceed. So key takeaway is AMP synthesis uses GTP, GMP synthesis uses ATP. All right, so now we shift from building purines from scratch to purine salvage, which is the body's energy-saving pathway. So de novo purine synthesis costs about 6 ATP, whereas salvage only costs about 1 ATP. So whenever possible, the cells prefer to recycle existing purine bases instead of rebuilding them. So the first important enzyme to know here is going to be hypoxanthine guanine phosphoribosyl transferase, or HGPRT. And this enzyme salvages hypoxanthine to IMP and guanine to GMP. The second is APRT, which converts adenine to AMP. In both cases, PRPP provides the ribose backbone and the free base is snapped back onto it. Simple, efficient, and metabolically pretty cool. Then we get to the big pathology, which is going to be Lesch-Nyhan syndrome. This is caused by HGPRT deficiency and is X-linked. When HGPRT is missing, purines cannot be salvaged, which has two major consequences listed on the slide. First, PRPP accumulates, which drives excess de novo purine synthesis. More purines being made means more purines being broken down. This leads to hyperuricemia because purines ultimately degrade into uric acid. Second, there are severe neurobehavioral symptoms. Classic presentation is going to be self-injury along with intellectual disability and dystonia. So if you see self-injury and gout, right, which we'll get into a little later, but that's a uric acid disease, you got to be thinking about Lesch-Nyhan. This slide also briefly notes adenosine deaminase deficiency, and that causes accumulation of deoxyribose, or ATP, right? So DATP, deoxy-ATP, which is toxic to lymphocytes and leads to SCID, or severe combined immunodeficiency. So the high yield takeaways here are going to be salvage saves energy, HGPRT, and it's linked to Lesch-Nyhan. And then you're going to have your adenosine deaminase deficiency and linking that to SCID. All right, now we're following purines to their final metabolic endpoint, which is uric acid. So the first line shows the pathway very clearly. You're going to go from purines to xanthine to uric acid. Humans lack the enzyme to further break down uric acid, so uric acid is the final waste product of purine metabolism. That's an important species fast fact there, and other animals actually can degrade it further, but we can't. The key enzyme highlighted here is xanthine oxidase. This is the final enzyme in purine degradation, converting xanthine into uric acid because it sits at the very end of the pathway. It's an ideal drug target. So that brings us to gout. Gout occurs when uric acid levels become really high, leading to uric acid crystals deposition in joints. These crystals trigger a strong inflammatory response, and classically, gout presents in the first metatarsophalangeal joint, okay, so the big toe. That location is emphasized on exams because cooler temperatures and mechanical stress promote crystal formation there. Next is allopurinol, which ties the biochemistry directly into treatment. Allopurinol is a xanthine oxidase inhibitor. So if you're basically blocking the enzyme that makes uric acid crystals, you're going to be able to treat gout. Now we switch from purines to pyrimidines. And the first thing the slide wants you to remember is that construction order is different. So for pyrimidines, the base is built first and ribose is added later. Easy way to remember that, pyrimidine sounds like pyramid. And to have a pyramid, you need a good base, okay? So that's the opposite of purines, right? Where that ribose comes first. They're pure, they're sweet. You're going to want that sugar first. Okay. Now, the other key distinctions. This is where that CPS2 comes in. And CPS2 is cytosolic. It is also activated by PRPP. It is inhibited by UTP. That's important because CPS2 is not the same enzyme as CPS1 in the urea cycle. Remember? Different location, right? Because the CPS1 was in the mitochondria of hepatocytes. And they also have different functions and different regulation. So the first fully formed pyrimidine nucleotide listed is UMP, the UMP. And UMP is the parent pyrimidine, which can then be converted into UTP or CTP. Think of it similar to IMP for purines. Then we're going to introduce orotic aciduria, a high-yield disease. This is caused by a defect in UMP synthase, which includes OPRTase and OMP decarboxylase. When this enzyme doesn't work, orotic acid accumulates. Pyrimidines can't be synthesized properly, and patients develop megablastic anemia. Crucially, this anemia is not corrected by vitamin B12 or folate, which helps distinguish it from other causes. Next is DTMP synthesis, which directly connects pyrimidines to DNA replication. The reaction shown is DUMP becomes DTMP via thymidylate synthase. This step requires THF, and it's a major drug target. THF is basically a carbon donor. We'll get into him. He has a whole slide. So 5-FU inhibits thymidylate synthase, and methotrexate inhibits DHFR, preventing THF regeneration. So I know that was a lot of just words thrown at you, but honestly, the biggest thing to take away from this is purines use that ribose first, pyrimidines do the base first, and I really recommend just looking up a pyrimidine synthesis chart and just drilling it. Like I said, similar to the amino acid stuff, a lot of the synthesis here is just going to be that blunt memorization that you're just going to have to draw out over and over again and drill. Okay, so here we're talking about THF and why this one carbon metabolism is so central. So one carbon transfer reactions move exactly what it sounds like, single carbon units, also called C1 units, between molecules. And these tiny carbon fragments might sound small, but they're essential for building and modifying major biomolecules. The slide then lists one carbon metabolism is essential for, like we said, so we have DNA and RNA synthesis. One carbon units are required to make purines and thymidine. So without this system, cells literally can't replicate DNA. Second, amino acid metabolism. Several amino acids donate or receive one carbon units, linking protein metabolism directly to nucleotide synthesis. Then we also have methylation, and this will be utilized in epigenetics, meaning DNA and histone methylation, phospholipid synthesis, neurotransmitter metabolism. So one carbon metabolism controls not just growth, but gene expression and signaling. And now we have three key players here. First, we have tetrahydrofolate, or THF, which acts as a carbon carrier. THF physically holds and transfers one carbon units in different oxidation states. Second is vitamin B12, also called cobalamin. B12 is required for methyl transfer reactions and molecular rearrangements, especially in linking folate metabolism to methionine metabolism. And then third, we're going to have S-adenosyl methionine, or SAM, which is the universal methyl donor in the cell. Whenever you see a methyl group added to something, SAM is almost always the source. So the exam framing at the bottom puts this all together, and basically if you disrupt one of these, you're going to disrupt DNA synthesis and methylation as a whole. That's why deficiencies in folate or B12 cause megablastic anemia and neurologic problems. Okay, so now we're going to zoom in on exactly how folate supports DNA synthesis, and the key message is simple. Without THF, you cannot make thymidine. The first bullet states that THF is required to make thymidine, which is one of the 4 DNA bases, right? That is the T in our GCAT. Specifically, THF is needed to convert DUMP into DTMP, and that step is absolutely essential for DNA replication. The key reaction on the slide is DUMP to DTMP via thymidylate synthase. In this reaction, the 1 carbon unit is donated by N5N10 methylene, THF. As THF donates that carbon, it gets oxidized to DHF, or dihydrofolate. So it goes from trihydrofolate to dihydrofolate. That means THF is consumed in the process and must be regenerated to keep DNA synthesis going. That regeneration step is handled by dihydrofolate reductase, right? So we're adding a hydrogen. So DHFR, or dihydrofolate reductase, is what's going to turn that back into THF. If DHFR doesn't work, the cell runs out of usable THF and thymidine synthesis stops. This is where drugs come in. So 5-FU, or 5-fluorouracil, inhibits thymidylate synthase, directly blocking DTMP production. Methotrexate inhibits DHFR, directly blocking DTMP production, preventing THF from recycling itself. So even though these drugs hit different enzymes, the endpoint is the same. If you decrease DTMP, you impair DNA synthesis. The board pearl here is that blocking THF recycling causes that megablastic anemia. That happens because rapidly dividing cells, especially bone marrow precursors, can't replicate DNA properly. So with B12, the big idea here is you're not going to be able to absorb B12 without intrinsic factor, which again is secreted by parietal cells in the stomach. This B12 intrinsic factor complex then travels intact to the terminal ileum, where it is absorbed via specific receptors. So the exam chain here is stomach acid, R binder, intrinsic factor, terminal ileum. Any break in that chain will lead to, because of like parietal cell loss, pancreatic insufficiency, or ileal disease, causes B12 insufficiency. So now the reactions that B12 is required for. So the first is methionine synthase, and B12 is required to convert homocysteine to methionine. This reaction also regenerates THF from methyl THF. So without B12, folate becomes trapped in its methylated form, the methylfolate trap, impairing DNA synthesis. The second reaction is methylmalonyl-CoA mutase, which converts methylmalonyl-CoA to succinyl-CoA. This step is critical for normal fatty acid and amino acid metabolism. Clinically, this explains the slide's last point, which is B12 deficiency will lead an increase in homocysteine and an increase in methylmalonic acid. That combination distinguishes B12 deficiency from folate deficiency, which raises homocysteine but not methylamonic acid levels. So, just to summarize it, B12 absorption requires intrinsic factor and the terminal ileum. B12 deficiency impairs DNA synthesis and neurologic function. And if you see that elevation in methylmalonic acid, you know it's a B12 problem and not a folate problem. Okay, this slide is fast but a critical concept. So SAM is basically your universal methyl donor in the body. SAM is made of methionine, and once formed, it donates methyl groups to a huge range of reactions. Anytime you see methylation, you should immediately be thinking of SAM. So examples include DNA and histomethylation, neurotransmitter metabolism, phospholipid, and hormone synthesis. So after SAM donates its methyl group, it becomes homocysteine. Homocysteine must then be recycled back into methionine, which requires vitamin B12 and folate. If that recycling fails, homocysteine accumulates. So the high yield takeaway is SAM donates methyl groups, and B12 and folate recycle homocysteine. All right, now we're just going to go over the clinical correlations. So first, what folate and B12 deficiencies have in common. Both of them are going to lead to megablastic anemia. That's because of that rapidly dividing cells, especially in the bone marrow, and they can't replace DNA properly. Both deficiencies also cause elevated homocysteine, since the reaction converting homocysteine to methionine is impaired. And as stated before, that critical difference is going to be that MMA, or that methylmalonic acid, okay, which you're only going to get from a B12 deficiency, not a folate one. Okay, and so the transsulfuration pathway, or the transsulfuration pathway, explains how the body handles excess homocysteine. Okay, homocysteine can be converted into cystathione and then cysteine through the transsulfuration pathway. This pathway requires vitamin B6 as a cofactor. If B6 is deficient, homocysteine cannot be safely diverted, leading to homocysteine accumulation, even if folate and B12 are normal. All right, so biotransformation exists for one simple reason: to make compounds easier to eliminate. So many substances that the body encounters, drugs, toxins, and endogenous molecules, are lipid soluble. Okay, that makes them hard to excrete because the kidneys are designed to eliminate water soluble compounds, right? Similar to those fat soluble vitamins, ADEC, right? So biotransformation converts lipid soluble compounds into more water soluble forms, allowing them to be excreted in urine and bile. And we'll get into how this is handled specifically in the next couple slides. But in general, all the foreign compounds that you're going to be dealing with are just called xenobiotics, okay? And as stated before, most of them are lipophilic and thus poorly excreted by the kidneys. All right, and now we're getting into some very high-yield stuff that you should just know cold. And this is phase 1 versus phase 2 biotransformation. So phase 1 reactions are about modification. They introduce or expose functional groups on a molecule through reactions like oxidation, reduction, or hydrolysis. The main enzyme system here is cytochrome P450, abbreviated to CYP450, which is located in the liver. Phase 1 does not necessarily make compounds safer. In fact, phase 1 metabolites can be more reactive or toxic than the parent compound. The purpose is to create a handle for phase 2. Phase 2 reactions are about conjugation. Here, the molecule is linked to a large polar group, such as sulfate or a glutathione. This makes the compound highly water-soluble, allowing for efficient excretion into urine or bile. So a key concept on the slide is that phase 2 can occur without phase 1, but phase 1 often exists only to prepare for phase 2. So some exam framing is just phase 1, you want to think functionalization. You're prepping it for phase 2. Phase 2 is actually where you're going to be doing the useful thing of conjugating it, and it's going to make it excretion ready. So phase 1 modifies, phase 2 solubilizes. All right, so this slide is just introducing CYP P450 enzymes as a whole, which are the workhorses of that phase 1 drug metabolism. So first, what they even are. They're heme-containing monooxygenases that use a heme group, like hemoglobin does, to insert one oxygen atom into a drug molecule. So CYP enzymes are found in smooth endoplasmic reticulum of hepatocytes. And when you see the term microsomes, that's referring to fragments of smooth ER where CYPs live. So what do they need for work? They need oxygen and they need NADPH. So if either oxygen delivery or NADPH supply is impaired, the activity of CYP enzymes drops. So the most testable part is that there's 6 CYP enzymes that handle about 90% of all drugs. The most important one, and the one that the slide is emphasizing, is CYP3A4. This guy alone metabolizes 50% of drugs. This is why this guy is going to be the default answer unless proven otherwise. If you're given a multiple choice question and that's on there, just click it. Just click. If you are lost, just click it. And so the others listed are also important but are less dominant. So finally, drugs can interact with CYPs in 3 ways. They can be substrates and get metabolized. They can be inducers and increase their expression. Or they can be inhibitors and decrease the expression of the CYP enzymes. All right, so this slide explains how drugs change CYP activity, and this is where most drug-drug interaction questions live. So let's start with enzyme induction. Induction means increased enzyme expression. You're literally making more CYP enzymes. With more enzyme available, drug metabolism increases. So the clinical consequence depends on the type of drug. For active drugs, induction causes decreased drug levels and reduced effects. For prodrugs, induction causes increased activation and stronger effects. So I like to think about it like this little guy slamming on the floor, okay? And since he's slamming the floor, if you are an already active drug, pretend that drug is on the floor, you are now breaking that drug. It's going to decrease its levels. So that's going to lead to a reduced effect. If you're a prodrug, though, if you imagine a prodrug like a little egg, and inside that egg is a nice and active drug, and you have this little guy smashing on the floor, if you smash that prodrug, you're going to increase the activation and cause a stronger effect. So classic inducers will be phenytoin, rifampin, phenobarbital, and chronic ethanol, especially inducing CYP2E1. So a high-yield clinical example that is shown is going to be phenytoin decreases oral contraceptive efficacy. So more enzyme, faster metabolism, lower hormone levels, and treatment failure. So honestly, with these drug names, just throw them on a flashcard and just drill it until you can name it off. So now with enzyme inhibition, inhibition means decreased enzyme activity. The enzyme is present, but it's blocked. That causes drug levels to rise, increasing the rise of toxicity. So the classic example is grapefruit juice, which inhibits our big boy CYP3A4. This increases the bioavailability of many drugs because less is metabolized before reaching systemic circulation. So the test logic at the bottom is pretty simple. So induction, it will be underdosing, and then inhibition is overdosing. Okay, so if you remember nothing else, try to remember that. And I hope my little guy analogy helped you out. All right, so now we're going to walk through acetaminophen metabolism, and this shows exactly why overdose causes liver failure. So let's start with normal dosing. At therapeutic doses, about 90% of acetaminophen is safely metabolized through phase 2 reactions. So specifically, sulfation and glucuronidation. Sorry about that, it's a bit of a mouthful. These pathways make acetaminophen water-soluble so it can be excreted in urine. A small fraction, normally harmless, goes through CYP metabolism, mainly CYP2E1, producing a toxic metabolite called NAPQI. Under normal conditions, this isn't a problem because NAPQI is rapidly detoxified by glutathione, abbreviated GSH. So at baseline, small amounts of NAPQI plus enough glutathione equals no damage. Now, the overdose scenario is the phase 2 pathways become supersaturated. Once glucuronidation and sulfation are maxed out, more acetaminophen is forced down the CYP pathway, aka phase 1, which dramatically increases NAPQI production. At the same time, glutathione stores are depleted, typically by about 70 to 80%. Without enough glutathione, NAPQI can't be neutralized. So free NAPQI then binds cellular proteins, causes oxidative damage, leads to hepatic necrosis, especially in zone 3 of the liver. That's the core mechanism of Tylenol toxicity. And now for the antidote, which is N-acetylcysteine, or NAC. NAC works in two ways. One, it replenishes glutathione. So, if you literally replenish the thing that takes care of NAPQI, pretty self-explanatory, you can detoxify NAPQI. And so the slide emphasizes timing. So it's best within 8 hours, but still beneficial later. And the board classic is that Tylenol toxicity, why is it toxic? And you just got to know high NAPQI levels, low glutathione. All right, so this final slide ties everything together and explains why all of this metabolism actually matters clinically. So start with the first pass effect. When a drug is taken orally, it's absorbed from the GI tract and travels through the portal vein directly to the liver before reaching systemic circulation. During this first pass through the liver, a significant portion of drug can be metabolized immediately, which reduces bioavailability. The slide gives a classic example, morphine. Morphine has a very high first pass effect, which is why oral doses are much higher than IV doses for the same effect. Next are drug-drug interactions, one of the leading causes of adverse drug reactions. So if two drugs are metabolized by the same CYP enzyme, they can compete, leading to altered drug levels. This is why knowing CYP patterns matters, because it can predict toxicity or treatment failures. Then the slide highlights genetic variability. Some people are slow acetylators, which can cause ionized toxicity. Others have CYP polymorphisms, meaning their enzymes work faster or slower than the average enzyme. Same dose could lead to a very different outcome. So the slide reminds you that liver damage, age, nutritional status, all can alter drug metabolism. That's why pharmacy is such a crazy specialty, dude. You could never catch me in a pharmacy. So I went to med school. I don't know if that was any better. A dose that's safe in a healthy adult may be toxic in an elderly patient or someone with cirrhosis, right? So the final takeaway here is that xenobiotic metabolism determines efficacy, toxicity, and dosing. So this entire section, CYPs, induction, inhibition, acetaminophen toxicity, first pass metabolism, all feeds into one clinical skill, which is predicting what a drug will do in a real patient. All right, guys, we finally made it to the very end. Thank you so much. This was a beast of a lecture to put together. I cannot believe it's finally done. Thank you for your patience. I hope that at least one of the slides ends up netting you a couple extra points on exams or helped develop your understanding on something that you were really running into a wall with. Remember, everything is additive. You will only get better with time. Keep running those flashcards, keep doing practice problems, talk with your friends, teach your friends, share this video. Thank you so much for stopping by Moosemed, where we take medicine by the horns. Stay frosty, folks.